My name is Alex Vitkin, and I'm happy to present the summary of our collaboration on the mega grant. A collaboration between my laboratory in Toronto and the Nizhny Novgorod State Medical Academy. And the title of our grant, or the theme of our grant, is Using Light to Enable Personalized Cancer Medicine. It was a third-year award. A few words about myself. I'm a professor of medical biophysics and radiation oncology at the University of Toronto, as well as having some other clinical and research duties as listed on the slide. So as mentioned, this is a collaboration between the Nizhny Novgorod State Medical Academy and my laboratory in Toronto, as well as the Institute of Applied Physics here in Nizhny Novgorod. So what are we all about? So the theme of the mega grant was using advanced optical or biophotonic technologies for monitoring and personalizing cancer medicine. The idea was to provide a multimodality imaging approach, subsurface volumetric imaging, of cancers and of, importantly, adjacent normal tissues and their response to therapy. The enabling technology was based on something called optical coherence tomography, something that's well known here in Nizhny Novgorod because some of the better developments of this technology occurred here as well as elsewhere in the world, as well as in my laboratory. So it was natural to combine our strength and the strength of the Nizhny Novgorod group to advance our cause. So the multimodality capabilities I'll show you later on was to look at several aspects of tissue, live tissues, specifically their microstructural information on cells and connective tissues, importantly microvascular information, so functionality of blood flow and perfusion. And something else we've developed recently is biomechanical properties of tissues, so tissue elastography, stiffness, and biomechanics. All this in a single package. And this package was not meant to only diagnose tissue, but also, more importantly, to monitor its response to therapy in an effort to improve and optimize and personalize the therapy as they're going on or shortly after they've occurred. And the therapies we've looked at is radiation therapy, abbreviated here as RTX, and photodynamic therapy, which is light-activated drugs used for oncology and beyond. And as I'll present very briefly, we had to tackle the scientific, the technological, the preclinical, as well as the clinical aspects of this relatively complex but very important problem. So one thing I want to stress is that this is a very highly interdisciplinary research, which brings with it lots of benefits and opportunities. So it brings together professionals from across different disciplines, and I list some of them here, notably physics, engineering, biology, as well as more clinical disciplines such as pathology and clinical oncology, different institutions such as Nizhny Novgorod State Medical Academy, Institute of Applied Physics, my home institution, the University of Toronto, and of course different countries, this being an international collaboration between Canada and the Russian Federation. The idea of having an interdisciplinary research team enables us to work on problems that are important, impactful, and address unmet clinical needs, and also, therefore, come up with potential advances that would have been impossible for any one discipline alone. It also creates an ecosystem for innovation, discovery, and clinical translation, and also enables us to build a training resource to train young scientists, the next generation of research and clinical practice leaders. So just summarizing briefly, our grant has been going on for 5 years, so just concluding now, starting in 2013. What were the big picture goals of the grant? So very briefly summarizing here is to assemble a multidisciplinary team, build a world-leading, world-class laboratory, develop and then test and validate enabling technology based on optical coherence tomography, and conduct preclinical and clinical and selected clinical studies, as mentioned before, on radiation therapy and on photodynamic therapy, and some specifics such as, for example, in the skin or in the gastrointestinal cavity, the upper gastrointestinal cavity, in the mouth and the oral cavity. So let's cut right to what we've accomplished. So I've broken this up along the lines of science, technology, preclinical, and clinical studies. So starting on with technology, we built several systems capable of this multimodality, obtaining of this multimodality information. Some of them are shown here. For example, here's a box that contains the core imaging engine, and here are some of the distal probes that are specific to the experiments and the applications in hand. That's very important. And some of this has been built, 3 different systems and several different distal probes with a modular design such that the probes and the systems are interchangeable and you can mix and match some of them. We've established a world-class laboratory as well as purchased some major equipment. So the space, some of the location is shown here and some of the equipment is shown on the bottom of the slide, as well as build some of the previous equipment that was shown on the previous slide. So let's briefly talk about the science and this multimodality approach that I keep mentioning. So here on the top is, on the left side are shown the 3 modes of operation of our systems. So the microstructural, which looks at cells and connective tissues. By the way, important to note that this is all in vivo. Angiographic, which looks at blood flow information, that's shown in the middle part of the slide, including some indication of how we use image analysis to improve the image quality. You can see in some of the blue circles on the right how much better it is than compared to the left. And the last part, which is the biomechanical properties of tissues, the tissue elastography. And then this multimodality holistic pictures where it allows us to look at things like microstructural information, combined with microvascular information, some additional image analysis, validation with histology, and for example, enables us to separate tumor vasculature from normal vasculature, as indicated by different colors here, and then monitor their differential response to therapy in an effort, again, to understand the therapeutic response and to modify the therapy delivery in response to the particular indications that are shown by the, in this case, the microvasculature. It's very important to continue the analysis of these pictures because pictures are very pretty and they make beautiful publications, but in the clinical context, people want numbers. So we want to quantify things and determine some quantitative metrics that can be used as predictors for response. So without going into any detail, but overall, on the left side is shown some of the approaches for quantifying the microvasculature. So starting off with rather beautiful looking initial pictures. Then we can do things like binarization or skeletonization, and then derive metrics such as fractal dimension, Euclidean distance, nearest neighbor, vessel length, and look at things like hypoxia or, again, response to therapy and so forth. On the right side is a similar approach, not a similar approach, but an analogous approach to quantifying the microstructural information. Again, looking at different metrics and coefficients, some of them which do work or some which don't work, and some are better predictors, in this case only showing the difference between normal and tumor, which in itself is very important. But again, the next step is to see how this longitudinally in vivo in time changes in response to therapy. So putting the science and technology together, here's a combined box, one of the systems that was built as part of this mega grant, which enables this multimodality imaging. And here, basically on a computer screen, on the computer monitor, is shown the 3 modes of tissue information that's available in vivo from one of our systems. So microstructural information on the top, this microvascular maps in the middle, and this elastographic indication of tissue stiffness or rigidity in the bottom, as well as 3-dimensional rendering of the tissue microstructure. So what do we do with all this enabling technology? How do we use it? So here are some typical examples of preclinical studies. So this is small animal imaging. This is before we get to patients, showing a couple of models we've used throughout this mega grant. So a mouse tumor model in the ear, the mouse ear, as well as the cheek pouch of a hamster. Very good control systems for doing growing tumors and monitoring pathology development, as well as monitoring the response to therapy. So here is shown some beautiful microvasculature we can see from these tumors, and also how they respond to therapy. So in this case, photodynamic therapy. And we're now able to derive some algorithms based on microvascular responses that give us an indication early on, immediately at therapeutic time or very shortly after therapeutic time, what is going to be the recovery of the patient or the outcome of the therapy. What is the therapeutic trajectory? So based on what the vasculature looks like within the tumor, and equally as important, what the vasculature looks like in the surrounding normal tissues, we can make these measurements and then give us the clinician indication what's going to happen in 3 weeks or 3 months when the therapeutic healing effect is complete. And having the ability to get this information, this multimodality information so early, gives us a possibility of modifying the treatment such that we get the outcome that we need, as opposed to waiting weeks or months for it and finding out that it may have worked or may have not worked. Shown on the bottom is also our initial efforts in quantifying elastography and seeing how that varies in time following therapy, and also seeing if these metrics also predict what is the final outcome, what is the treatment trajectory going to be for this particular patient. So that was, preclinical. A couple of examples of clinical work. So this is showing skin tumors, skin cancers, basal cell carcinoma, and a similar study, so longitudinal imaging shortly before the initiation of therapy, in this case photodynamic therapy, and at different times following, and showing the center of the tumor and the so-called surrounding normal or partially involved nearby regions of the tumor, and seeing how they vary in time. And again, we could form some quantifiable metrics of responders versus non-responders, which again allow us to modify treatment based on some early multimodality information. Taking this a step further, this is a preclinical clinical pilot study with radiotherapy patients. Radiotherapy is exceptionally important because it's used in 50% of all cancer treatments, so millions of people worldwide per year undergo radiotherapy, and it's a very effective therapy, but sometimes in about 20 to 30% of the cases the outcome is unpredictable or the side effects are unacceptable. So here showing an intensely modulated radiotherapy plan of a head and neck tumor. So the tumor is on the left side here. The white arrows indicate the regions where we probe with our OCT distal probe. In this case, the microvasculature is only shown here. We also have microstructural information for this patient as well. And you can see that the vascular metrics, the quantifiable numbers we're developing here, differ for the left cheek and the right cheek, which is not surprising because the dose delivered is very different. What is important here to note is that the arrows indicate the clinical onset of quite a severe condition of radiotherapy toxicity called mucositis. However, if you look at the blue curve, this quantifiable metrics, we can see the onset of this way before the clinical manifestations. So having this type of information allows us to potentially mitigate these debilitating side effects of radiotherapy and also alter radiotherapy suitably. And shown on the right side are just some panels of the three-dimensional microvasculature obtained in vivo in live patients that enable us to derive these numbers. One or two slides on some metrics of success of our grant. So publications. So over the 5 years, we've published 23 papers in respected journals, obviously peer-reviewed, in Index on the Web of Science. That's been cited about 600 times so far over these 5 years. The journals vary across the board, so some indicate some examples here. Impact factor of scientific reports, anywhere between about 5 to about 3, and some others as well. Both the examples selected here are so-called in the top quartile of journals, so these are really respected journals in the field. We've also received several patents, so 3 patents received and 1 under review applied for this work. It's very important to train the next generation of scientists and engineers and clinicians that can continue this work so it doesn't stop after the grant is over. So we've developed a lot of courses, and HQP, sorry, stands for Highly Qualified Personnel. So there's been some new courses, de novo courses developed based on optical coherence tomography, multimodality imaging, and applications, as well as continuing education courses is listed here. Also, some young scientists have defended their PhD, 7 of them, 3 got Doctors of Science, and 1 Doctor of Science work is in development or about to be defended. Also, continuing along the same theme of education and outreach, there's been a lot of conferences, some of which we co-hosted and some of which we just simply participated in. So including about 40 international ones and about 30 local in Russian Federation. We had a lot of seminars, a lot of exposure, external as well as internal, about 90 seminars, of which half I participated in person. So where does it stop, or sorry, where does it continue from here? We don't want it to stop. So what are the next scientific, technological, preclinical, clinical, and commercial steps? So on the scientific side, as I mentioned, elastography development is relatively recent, so we need to continue some of the imaging and image analysis along this vein. It's exciting to potentially look at other structures, vessel structures, not blood vessels only, but for example, lymphatic vessels, very important in tumor response, and also in general, just looking at interstitial fluids. We're continuing along those lines. As I mentioned before, the probes, the distal probes that are adjacent or sometimes in contact with the patient or with the clinical or preclinical animal systems are very important, and so they have to be task specific for the goal at hand, and they're continuing to be developed. And some of the systems we've already have developed, I mentioned 3, are going to undergo clinical certification and potential commercialization steps afterwards. So develop OCT imaging systems. And where does this go beyond what we've done in terms of the next clinical steps? So some of the routes we've identified and are already pursuing in part include breast lumpectomy guides, so partial breast surgery and looking for clear margins in breast lumpectomy. Brain gliomas, and again, the task here would be to have negative margins or clear post-surgical margins. Looking at alterations in blood flow in lower GI, so intraoperative gastrointestinal ischemia, and potentially other applications. All right, so let's summarize. Using the Russian term of itogi pятилетки, what are our take-home messages here? So the first one is probably the most important. That is, multimodal optical coherence tomography enables some unique in vivo visualization of tissue structure and function, and not only of tumor tissue, but also adjacent normal tissues. And importantly, supplies treatment monitoring information that can be used for personalizing minimally invasive cancer therapies. So modifying, individualizing, making personal medicine or individualized medicine. We've developed enabling technology. We've conducted preclinical and clinical feasibility studies. We have built a world-class laboratory based on low optical coherence tomography and established a highly qualified personnel training resource. And we've identified future directions that can continue this work forth. Hopefully this is not the end, but this is my final slide. I'd like to thank the Nizhny Novgorod Medical Academy, the Institute of Applied Physics, all the collaborators here, and in particular, I'd like to mention Dr. Elena Zagainova, who was my co-PI on this grant and who introduced me to this program in 2012 or so, and Dr. Natalia Gladkova, who was also a major player in this grant and greatly enhanced our ability to carry forth what was needed to be carried forth. and Dr. Boris Shahov, who is was director of the Nizhny Novgorod State Medical Academy, who also was very helpful and supportive of all our efforts. Thank you very much, and we'll now take some questions.